Assalamualaikum Dr. Heri.
Waalaikumsalam.
Jelas suara saya dok, izin?
Jelas sekali.
Sambil kita nunggu peserta yang lain dok, untuk kita mulai
Ya.
saja gitu.
Ya.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon everybody. Thank you for your attention. Thank for all the speakers. Thank for all the participants. Now we are going to short satellite session. That is functional session 1. Will be led by Dr. Heri Subianto. Before that, let me introduce curriculum vitae of Dr. Heri Subianto. Dr. Heri Subianto is one of medical staff department in neurosurgery in Sutomo General Hospital. He was graduated from Medical School Erlangga University in 2006, and then also graduated from neurosurgery in 2015 at Erlangga University, and the last postdoctoral fellowship 2017. Well, Dr. Heri Subianto, time is yours. Maaf dok.
Thank you so much for the introduction. Thank you for committee for giving me opportunity to chair this very interesting symposium. Luckily, we the situation, but actually we hope that it will end soon, and then we can meet together, share, and cheer together. But otherwise, let's start this meeting, this functional meeting. We have already 4 presenter. We already know all of the speaker, and let's start. For the first is, can committee please show the curriculum vitae? The first session will be presented by Dr. Ahmad Fahmi with the title Neurosurgical Management for Torticollis. Dr. Fahmi already here.
Okay, thank you very much, Dr. Heri.
We already know Dr. Fahmi.
Great opportunity
Pioneer
to
for
see you all in this meeting.
Brain stimulation, yeah.
Okay, thank you very much for the committee and the Asian Congress of Neurological Surgery and Indonesian Neurosurgical Society. Please, you can play the pre-recorded video I already sent to the committee. We can start about the torticollis. Please, the committee.
Yes, sir.
Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the opportunity to share about neurosurgical management for torticollis. Before we know about the intervention for torticollis, we should know that torticollis is a part of cervical dystonia. Cervical dystonia is a painful condition in which your neck muscles contract involuntarily, causing your head to twist or turn to one side. These are patterns of cervical dystonia. Horizontal rotation, we called it torticollis. Another pattern are laterocollis, retrocollis, and antecollis. Different parts have different corresponding muscles. This is very important because at selective peripheral nerve denervation, we denervate the nerves that innervate the corresponding muscles. For torticollis, the corresponding muscles are contralateral sternocleidomastoid and ipsilateral splenius capitis with semispinalis capitis. And for laterocollis will be ipsilateral splenius capitis, semispinalis capitis, and levator scapulae. And for antecollis will be bilateral sternocleidomastoid and scalene muscle. And the last one for retrocollis, we need to denervate nerves that innervate bilateral splenius capitis, semispinalis capitis, and upper trapezius. Etiology of cervical dystonia are 80 until 90% idiopathic, 10 until 20% post-traumatic. And another cause will be chronic neuroleptic drug can cause tardive dystonia, psychological factor like depression and anxiety, and other neurological problem like adversive seizure, homonymous hemianopsia, ocular disturbance, ocular palsy, and so on. And until now, pathophysiology concept still unclear. Another history were start at 16 and 41 from myotomies of the sternocleidomastoid, and until 1990, they are developed microvascular decompression. And before that, GPI pallidotomy was done by Munzinger, and in 1990, bilateral GPI DBS was started. Medication that we can use for cervical dystonia are combination between clonazepam, trihexyphenidyl, and baclofen. Sometimes levodopa could respond to levodopa-responsive dystonia case. Neurosurgical intervention for cervical dystonia, including selective peripheral nerve denervation, globus pallidus internus pallidotomy, and GPI deep brain stimulation. Now we start to look about selective peripheral nerve denervation. It was pioneered by Keane at 1891. He was performed denervation in division of spinal accessories nerve and posterior branch of C1, C2, and C3. He wrote article that entitled Spasmodic Wry Neck. In 1970s, Bertrand was performed his technique to treat selective peripheral nerve denervation. His technique including denervation of complete extraspinal, extradural from C1 until C6 unilateral or bilaterally, and sometimes combined with myotomy of the corresponding muscle. Now the indication and patient selection. We can perform intervention in cervical dystonia if no response to medical treatment, no response to repeated Botox injection is about 6% until 14%. Sometimes combined procedure needed. And be careful in myoclonus and dystonic head tremor because they are poor candidate for selective peripheral nerve denervation. And then how the strategy to deal with cervical dystonia? The first, if it's pure cervical dystonia, we need to make sure the patient had simple tonic cervical dystonia or complex movement. If the patient had simple tonic cervical dystonia, we can try medication. If no response, we can try Botox injection or combination between medication and Botox injection. And we can perform selective peripheral nerve denervation if those treatment didn't work. The second, if the patient had complex of cervical dystonia or patient had cervical dystonia with extracervical syndrome, for example, patient also had truncal dystonia or another dystonia on another parts of his body, we still can try medication first. And if no response with medication, we can perform a step GPI pallidotomy or bilateral GPI DBS. And if there are any residual symptom, we can add selective peripheral nerve denervation. The primary goal of intervention will be selective weaken dystonic muscle while preserving muscle mass, normal muscle. Stage procedure may be necessary for optimal result. And for GPI pallidotomy and GPI DBS will be control the dystonic movement. Now we look again about corresponding muscle of torticollis. Once again, this is very important because at selective peripheral nerve denervation, we denervate the nerves that innervate the corresponding muscles. For torticollis, the corresponding muscle are contralateral sternocleidomastoideus and ipsilateral splenius capitis with semispinalis capitis. This is the scheme of the selective peripheral nerve denervation for torticollis. For posterior part, we use microscope during surgery. It is different if we did spinal surgery. In this surgery, we keep semispinalis cervicis muscle on his place, and we just walk between the semispinalis cervicis and semispinalis capitis muscle until touch the lateral part of and posterior part of the lateral mesh. And we identify the posterior branch of C3 until C6 ipsilaterally and of the torticollis. And usually we recheck the location using X-ray during the surgery. And for C1 and C2 denervation, we usually perform using Tyra procedure. For that, we did hemilaminectomy of C1 like this. And for C1 and C2 denervation, there are two techniques that we can do. The difference between those techniques are the difference of C1 and C2. In Bertrand procedure, in Bertrand technique, he did extraforaminal denervation of C1 and C2. It means that motoric and sensoric part of the nerve were cut. Usually the patient had numbness at occipital area after surgery. Another technique promoted by Professor Takumi Taira, that denervation of C1 and C2 done intradurally. He just cut the ventral part of the nerve to avoid sensory nerve from C1 and C2. And we need to very careful during denervation the C1 nerve and C2 nerve, during denervate the C1 nerve, because it very close with vertebral artery that showed at this picture. Like this, it is very close with vertebral artery. At this video, we looked at, we confirm using X-ray and mark the C3 until C6. After we calculate using bipolar and cut using microcisor, we did this one by one until C3, C4, C5, and C6 denervated. Like this, calculation and cut with microcisors, C5 until C6. And we must make sure this nerves already denervated. And then we continue to do the hemilaminectomy of C1, open to dura mater, and after we identify, and then after that, we identify the ventral part of the C2 and dentate ligament. Like this, we looking for the dentate ligament, we looking for the C2 at ventral part, ventral root of C2. If we found the C2 ventral part, we calculate and cut using microcisors. And we looking for the another ventral root of C2, usually is more than one. We need to coagulate and cut the nerve to make sure there is no ventral part of the C2. After that, we explore the C1 nerve in the ventral part. We identify the dentate ligament, and then we look this. It is very close with vertebral artery. We need to be careful, very careful, and we calculate using bipolar and cut using microcisors. And after that, we close dura mater, watertight, yeah, like usually we must make sure there is no liquor cerebrospinal leakage after the surgery, and then we close the skin. After that, for the anterior part, we need to denervate the accessories nerve branch to the contralateral sternocleidomastoid muscle. And then we calculate, if we found the branch, we calculate and we cut using microcisor. After that, we evaluate the bleeding. This is the incision in the cervical area, in the anterior parts. Okay, another intervention will be pallidotomy and deep brain stimulation. These are MRI. The patient after GBI pallidotomy for the GBI target is posteroventrolateral of the GBI near the GBA. this is in coronal section. It's just above the lateral border of optic tract, like this. In pallidotomy, we make a lesion about 3 millimeters in diameter using radio frequency equipment, and we encourage this procedure done subsequently, not at one time procedure. It is very dangerous if we do it in one time. And this is MRI of the patient after bilateral GPI DBS. We can see the electrode of the DBS placed properly at the bilateral GPI. It is coronal section, and this is axial section. In this stereotactic procedure, accuracy and precision, in this stereotactic procedure, accuracy and precision is very important. The error should not more than 1 millimeter. And for conclusion, neurosurgical intervention needed when another treatment have failed. Patient selection is very, very important. Combined intervention may be needed in some patient. After surgical follow-up, like medication, physiotherapy have an important role too after the surgery. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much for the excellent presentation from Dr. Ahmad Fahmi. As we know that functional neurosurgery is quite a rare case, especially for neurosurgery community in Indonesia. Okay, we have some question for Dr. Fahmi.
Excuse me, sir. I'm sorry. The question will be discussed end of session, 10 minutes. So we continue the presentation.
Okay, we continue the presentation.
Yes.
Okay. Sorry.
Because Dr. Mahendra sent video, we play the video.
Okay.
Thank you, sir.
For second presentation, this is a video presented by Dr. Made Agus Mahendra Inggas, MD, PhD. He is Chairman Department of Surgery and Neurosurgery Muhtar Yadi Comprehensive Cancer Center, Siloam Hospital, Semanggi, Jakarta. The first title will be Interventional Oncological Pain Management, Lower Visceral Pain. Committee, please play the video.
Thank you very much for the moderator for the introducing, and thank you very much also to committee that inviting me here in second Asian Congress of Neurological Surgeons. Now I will present and talk about the interventional oncological pain management, especially in the lower visceral pain. I will share my presentation. Okay. Interventional oncological pain management, lower visceral pain. As you know that cancer is the mostly deadly of the disease in the recent years, and also mostly of the cancer patient have pain. We call it the pain, cancer pain. Usually they are like second disease that patient facing during his life. So interventional oncological pain management is very important for the patient who suffering the cancer is really in advanced stage. Disclosure statement. I have no relationship with the financial or commercial to the other pharmacies or drugs, medicines. As a background, patient with pain caused by cancer frequently experience visceral pain. Cancer with extensions into the lower abdominal and pelvis may experience severe pain that is unresponsive to oral or parenteral opioids. Also, excessive sedation or other side effects may limit the acceptability and usefulness of oral opioid therapy. Therefore, a more invasive approach is needed to control pain and improve the quality of life of these patients. A lower abdominal and pelvic pain block is possible because the afferent fiber innervating the structure travel into the sympathetic nerve, trunk, ganglia, or remi. Thus, sympathectomy of visceral pain is analogous to peripheral neurectomy or dorsal rhizotomy for somatic pain. Recent studies suggest that visceral pain is an important component of the cancer pain syndrome experienced by the patient with cancer of the pelvis, even in advanced stage. Thus, percutaneous neurologic block of the superior hypogastric plexus and impar ganglion should be considered more often in this particular case. As we know, the pathomechanism of visceral cancer pain has several causes. The visceral pain in cancer patient can due to distance or contraction of the hollow visceral walls, stretching of the capsules in the solid visceral organs, compression or traction of ligaments, vessels, or mesentery, formation of inflammatory mediator release secondary to tumor infiltration of visceral structure, compression or invasive of neural structure supplying the viscera, stretching of serosal or mucosal surface, and ischemic caused by tumor invasion or compression of visceral blood supply. Superior hypoglossal plexus is located on the anterior lumbar 5 to sacral 1. And location of the ganglion impar is the tip of the sacral 5 in between coccygeus and sacral discus. In general, contraindication of the neurologic block of symptomatic pathways, including tumor invasion into the insert site, coagulopathy, systemic or localized infections, complicate anatomy, and bowel obstruction. Fluoroscopy, ultrasound, and computer tomography guide assistant are commonly used to aid with procedural guidance and to ensure accurate needle placement near the target location. Here in table 1, several targets of sympathetic axis blocks and our series during 3.5 years. As we know, superior hypoglossal plexus located in L5S1 usually indicated for lower abdominal and pelvic pain. Impar ganglion in the anterior of the coccyx, usually indication for perianal or vaginal pain. The other side, there are several sympathetic axis and location or level. Procedures of superior hypogastric plexus block and impar ganglion block. Usually we have two procedure, two kind of the procedure is a lateral or classic procedure or technique and transdiscal technique. Usually we have use drugs combination of 1% of lidocaine or 0.25% bupivacaine, combination with dexamethasone as a steroid, and alcohol 95%. We need several needles, but usually I use for hypogastric blocks radiofrequency needles is long 15 centimeters and 20 gauge. And for impar ganglion block, usually we use a spinal needle with a long 80.8 centimeters. Either we use 22 gauge or 25 gauge. It depends on the patient and the discuss. So in the first step, we position the patient of prone position. Usually we put the pillow under the abdomen or stomach to make lordosis become decrease of the lumbar. And tube of the X-ray is positioned in far cranial position in the first step for make a squaring of the border superior sacral one. And then we move to the lateral, the tube, right or left, depend on the position, and make a scotidoc view. And after that, we insert the needle below the head of scotidoc transdiscal until 1 and 2 millimeters anterior of the L5S1 discus. The next step, if it's very simple for hypogastric plexus block and inferior ganglion blocks, needle inserted transdiscal between sacral and coccygeal with the tube and the view and the true lateral position. Usually I use transdiscal technique because we can clearly see the needle insert to the anterior part, and also with one insertion we can make midline position of the needle, tip needle, and then we just only doing in the one position or one side, and then effect is both side. According to several paper, this procedure is earlier is better, and also transdiscal is better, and combination of both is much better, according to Ahmed, PG et al. 2015. This is our sample case. In the first view is oblique position. We have to squaring the sacral one, and then oblique to the lateral view, or right or left 30, 25, 30 degree, and then we see one clear area or white dot area below of the scotidoc face, and then that is the target of the needle. It threw in between lumbar 5 and sacral 1 transdiscal until 1 or 2 millimeter anterior to the discus, and then we prove and evaluate with the contrast, 50% water and 50% contrast, to see if to show if the position is correct. And then usually I use lidocaine for combination with alcohol 55 because just alcohol 55 is very irritation and very a pain for the patient, so burning sensation. So I usually combination with the lidocaine and dexamethasone for side effect. This is impar ganglion block, transdiscal also. This is lateral view. So we insert in 22 or 25 spinal needle until 1 to 2 anterior of the coccygeal, sacrococcygeal discus, and then proving with the contrast if the location is okay. So we can inject the alcohol 45% with the combination. Superior hypogastric plexus block usually indicated for bladder, prostate, testis, seminal vesicle, descending and sigmoid colon, uterus, ovaries, vaginal, fundus, and rectum. Usually, complication that we are facing is usually back pain, but orthostatic hypotension, diarrhea, retroperitoneal hematome, bladder or ureteral injury, and it adventured or unproposed somatic nerve damage. But during this series, our case series, there are no complication we're finding out about the superior hypoglossal plexus block. Impart ganglion block usually provide block pain for perineal, distal rectum, anus, or distal urethra, vulva, and distal third of the vagina. Usually we use the impart ganglion or even we combination with the superior hypoglossal plexus block. Usually little complication for impart ganglion block is a motor, sexual, bladder, or bowel dysfunction, or even perforation of the rectum. These several studies of superior hypoglossal block plexus and the result, mostly of these cases shown more than 50% of the decrease of the FAST score and decrease of the opioid consumption, including our series. This is studies for ganglion impart block. Several cases is very promising, usually for perineal pain or pelvic advances pain, or even coccydynia by trauma. We can grab the good result, more than 50% of FAST and opioid consumption reduction. So conclusion, the invasive approach is needed to control of visceral pain due to cancer with extension into the lower abdominal and pelvis that is unresponsive to pharmacologic therapy. The benefit of neurolysis of the sympathetic axis, including improved analgesia, reduce opioid consumption, favorable economic implication, and superior clinic effect due to deleterious properties of high-dose chronic opioid therapy and improve the quality of life of patients. Superior hypoglossal plexus block and impart ganglion block has been shown to be an effective and safe approach to treat visceral pain in lower abdominal and pelvic cancer pains. And this technique should be known in the armamentarium of the pain physician or neurosurgeons as a useful adjunct to oral pharmacology treatment. This is the reference that I use. Several references the textbook for the pain physician usually, and I grabbed several specific cases as journal for superior hypoglossal block and inferior ganglion blocks. Thank you very much for your attention. Thank you.
Okay, thank you, Dr. Inggas. I saw Dr. Erliano already raise hand, but wait for a moment. We have to finish all presentation. So we continue to the third presentation, still coming from Dr. Mati Agus Mahindra Inggas with the title Experiences on the Brain Stimulation, Challenges and Outcome in Single Institution. Committee, please play the video.
Thank you very much for the moderator for introducing me, and thank you very much for committee that inviting to me here in Second Asian Congress of Neurological Surgeon. Let me share my screen for okay. My talk today is the experiences of deep brain stimulation, challenges and outcome from a single institution. We in Parkinson at Movement Disorder Center in Siloam Hospital Kebun Jeruk, Jakarta. Disclosure statement, we absence of any commercial or financial relationship, financial support from any kind of medicine or pharmacist. The first is we talk about the UK Brain Bank criteria for the Parkinson disease. There are several criteria for diagnosis of Parkinson disease. Essential criteria, the patient should have bradykinesia plus at least one of the racing tremor or rigidity or postural instability. Supportive criteria, patient should have unilateral onset or asymmetrical response to levodopa and progressive. Red flags. What the red flags? Red flags in diagnosis of PD, the patient should be have no gas palsy, because the gas palsy belongs of the PSP, progressive supranuclear palsy. If the patient have early dementia, maybe the patient diagnosis not a PD but a DLBD, degenerative Lewy body disease, or maybe have early falls. Usually in PD, falls happen in end stage or late stage. But if the patient have early falls, maybe the patient have PSP. If the patient have apraxia, so maybe the patient diagnosis is CBD, central basal degenerative. Some patients MSA, multi-system atrophy, is very similar with PD, but in patient MSA, autonomic symptom is prominent, should be have ataxia in the motoric symptoms. And for predominant lower limb involvement, usually the patient maybe have a vascular Parkinson or normal pressure hydrocephalus rather than typical PD. If the patient have exposure to neuroleptics, maybe patient have DIP or disease or dyskinesia induced Parkinson's, drugs induced Parkinson's. Extensive fat method changes in MRI usually belongs of vascular Parkinson's, and increased ventricle size belongs of normal pressure hydrocephalus, not in typical Parkinson disease. So patient candidate requirement for DBS usually short duration have benefit from dose of levodopa, substantial motor benefit from oral medication, or the patient have of side effect by dopa induced. This is quality of life diagrams that DBS usually goals of DBS is prolong good quality of life. Usually DBS is prevent to more decreasing quality of life when the patient become wheelchair or bedridden only. So DBS is prevent and make quality of life longer than a natural history of the disease. Our patient in our institution in Siloam Kebun Jeruk is 40 patients, and Siloam group is 51. Main age of group on DBS is 65 years. This is duration, while DBS done average of 8 years. This is severity, while DBS done and score 4 1 and years. Mostly the patient we did is male, and mostly also the DBS is located in bilateral STN. Only one a patient have bilateral GPI because of severe dyskinesia because of the medicines. This is follow-up. UPDS Part 3 is a motor function. 1 year, 27 patients. Now we still collect the data to 2, 3, and 4 years. According to 1 year's follow-up, the UPDS Part 3 motor symptoms is increased significantly to 67%. How about the quality of life? Parkinson Disease Questionnaire 39, the patient after DBS 1 year is improving 58% in the all item except and social and cognitive. DBS is not very improve or influence, but another items like mobility, activity daily living, emotional, stigma, communication, and pain is very improving. Success rate 97.5% is very high because during our cases, just only one cases have complication related with surgery is venous intracerebral hemorrhage in subcortical and cortical area. Decrease of the medications rate was average 60%. And here is a very interesting 3 DBS cases still off medication or without drugs in the long-term follow-up. 2 cases at 1.5 years until, and even Mr. H 7 years without medication. 3 DBS cases are death due to old age, cardiac problem, and sepsis or pneumonia. It's not related with directly with DBS. I tried to comparing of treatment of best medical treatment, lesioning, and DBS. According to indication, DBS usually indicated for grade 2 until grade 4. Lesioning usually in the early grade, and best medical treatment is all grade. The significant difference is outcome of the motor function or PDRS3. DBS is 43 until 74%, but lesioning is lower than that, 35%. Outcome of the OPDRS2 or quality of life is DBS more superior. Drug reduction, usually DBS also superior. However, the clinical effect or clinical indicated, BMT and DBS usually indicated for all symptoms of Parkinson, but lesioning usually indicated for the tremor and dyskinesia. Endurance, as our patient, we have until now more than 5 years. The DBS effect is still okay, more than 5 years. And how about the tissue damage? Is the very hot tissue that lesionings have a permanent effect, but DBS is temporary. The complication is exactly the same, but the cost, DBS is very costly. Maybe DBS is 3 or 4 times more costly than lesioning. But comparing of three kind of treatment, the BMT is very expensive. And for MDS, Movement Disorder Society standard, BMT and DBS is already standard. And lesioning, the standard is only unilateral pallidotomy. Limitation of the DBS. Until now, exact mechanism of the DBS is still unknown. Only alleviate symptoms, does not act as a cure. Surgical complication, risk of infection and bleeding, not beneficial to all patients suffering from PD. So that's why we have to take care about the indication and selective of patient, and need battery need to be changed every 5 or 9 years. Challenges, medical factors. In medical factor, equipment and support is still costly and very expensive. And Indonesia especially is very lead few movement disorders specialists. A non-medical factor, economy. Until now, government insurance, BPJS or national insurance is not totally coverage of the surgical cost. Geographically, a long distance from health center because we are archipelago countries, patient education, patient expectation, and referral system is not uh, developed well. So in conclusion, deep brain stimulation is the gold standard surgical procedure for the Parkinson disease. There are still many challenges to be faced in treating Parkinson disease with DBS. DBS actions in our institution are as good as the results from the best DBS center abroad. Thank you very much for your attention.
Thank you. A great presentation from Dr. Ingas. Any question for Dr. Ingas, please type on the chat box, and if we still have time, we will discuss together. Also for another speaker. Okay, we move to the fourth presentation will be presented by Dr. Noor Ul Huda Maria. She is a neurosurgery resident in Lahore district, Punjab, Pakistan. She will present with the title Epilepsy and its Surgical Management in Low Middle Income Countries. Where are we standing? The scenario, scope, and challenges. Video is already in the committee, and please play the video.
Greetings, I'm Dr. Nurhuda Maria, neurosurgeon for Pakistan, and I'm really honored to present my humble work for the ACNS. The topic of my presentation, the title of my presentation is Epilepsy and its Surgical Management in the Low Middle Income Countries. Where are we standing? And the scenario, scope, and the challenges. As we all know, epilepsy surgery is performed for medically refractory seizures with the goal to achieve better seizure control without causing loss of brain function. It is a very promising yet an underrated and underutilized option for drug-resistant epilepsy, especially in the low-middle income countries. Epilepsy affects about 2 to 3% population of the world, but it has an unequal distribution in the low-middle income countries. We can very well depict it as 80% of the epileptic patients reside in the low middle income countries. Partially, this is explainable because of potentially preventable causes such as perinatal injuries, CNS infections, and trauma, which are fairly more common in the low middle income countries. We will take this topic again later in the slide in the presentation. Ironically, it's unfortunate that about 33 to 75% of patients do not receive any sort of treatment at all for their epilepsy, and the number of surgeries is very sparse, especially in the low middle income countries. The situation is very grave. Even with maximal medical treatment, in at least one third of the epileptic cases, the epilepsy becomes intractable later. While epilepsy is the 36th leading cause of DLIs globally, in some of the low middle income countries that include Latin America and Western Sub Saharan Africa, it rises to the 21st and 14th cause of DLIs, respectively. That is very high. When we performed our study, we just wanted to have a view of the current status of epilepsy surgery in low-middle income countries, and we really wanted to know what are the challenges which the neurosurgeons of low-middle income countries do face and to consider that are causing hindrance in the development of this sort of surgery in the low-middle income countries. We collected data from neurosurgeons from LMIC that include, of course, Pakistan and India, Bangladesh, Afghanistan, Libya, Syria, Iraq, and Egypt, and inquired about the following few questions. Number one, the availability of epilepsy surgical facilities in their countries. Number two, do they regularly perform epilepsy surgery? Number three, are the trainees being taught epilepsy surgery? And is there the fourth was, is there any training program available for epilepsy surgery in their countries? Number five, is there at least one dedicated epilepsy center in their countries? Number six, what is their assessment of patient interest in getting operated for epilepsy control if they have the facility to do so? The level of neurosurgeon joining the level of interest of neurosurgeon joining epilepsy surgery as a subspecialty was also an important question which we asked to all of our participants, and we also reviewed articles in PubMed, Scopus, Curious, and ResearchGate on the availability of epilepsy surgery, specialty training in epilepsy surgery, dedicated tuners, most commonly perform epilepsy surgery, and the challenges. Of course, when you have a look on the number of epilepsy centers, surgical centers that are available in a country, and any epilepsy training program, then we can also assess and judge how much can be how many challenges and hindrances there would be. The scenario, according to a survey conducted by WHO and the ILA, International League Against Epilepsy and International Bureau of Epilepsy in 2006, epilepsy surgery is available in only 13% of the low middle income countries compared with 66% of high income countries. Over 73 to 75% do not receive any treatment at all, like I have discussed before. So what we learned here in Pakistan, the National Epilepsy Center, epilepsy just a center, not a surgical center at all, was established in 1989 at JPMC Karachi. The first epilepsy surgical center was established at the Aga Khan University. It is a private sector hospital, and it's a bit costly. However, still there is neither any national guideline nor any specialty training in epilepsy, surgery available in Pakistan. Level 3 epilepsy centers are available in the LMICs that include Philippines, Thailand, and Vietnam. And Indonesia and Thailand have also level 4 epilepsy care centers. More than 39 centers have been performing epilepsy surgeries in India regularly, and most of them are well equipped. In Bangladesh, epilepsy surgery is developing quite rapidly. Many young neurosurgeons of our generation, especially working at public sector hospitals, have never been exposed to any sort of epilepsy surgery, so they do not even have any idea how is it performed and what procedures are being performed. In our survey, results show that only 10% of neurosurgeons admitted to have observed epilepsy surgery during their careers. The commonest, these include the young neurosurgeons of our age group who have about 10, maximum 10 years of experience. The commonest epilepsy surgery to the ones who have observed epilepsy surgery was temporal lobectomy, anterior temporal lobectomy. 25% had epilepsy surgery performed in their countries. 60% said that they find patient interested in epilepsy surgery, and if it is available in their countries, they would certainly go for it. 30% had at least one dedicated epilepsy management center in their country. 60% neurosurgeons showed interest in joining epilepsy surgical training as their future specialty. Only 20% had a national training program for epilepsy surgery available. And in question related with challenges for epilepsy surgery, all agree that it is because of lack of trained personnel who could train the other neurosurgeons. 70% mentioned that their hospitals are not well equipped and the doctors are not interested in getting, the senior doctors who are mentors and supervisors, they are not much interested in getting trained and training the next generation of epilepsy surgeons because they are already much busy in their careers. 60% mentioned cost of surgery is a challenge in their country. That's very true. So we concluded that epilepsy is a huge, yet an ignored issue of the low middle income countries where it should be, it this whole scenario could be, needs to be highlighted, and there is a need to develop more awareness in order to implement some certain fixed guidelines, to design and implement those guidelines, and also to highlight the importance of epilepsy surgery. There is a lack of management facilities for available for epilepsy in low middle income countries. As I have said before, a huge chunk of patients do not receive any sort of treatment at all. And there's also a lack of awareness, and some people even consider it a stigma. And they usually go to local, quacks and hakims, and just go think that there is some sort of evil spirits who have taken over a person, and it's epilepsy. And if someone gets to know that one is, some person is epileptic, they consider it a stigma, and this should be addressed. Behavioral changes and awareness is very important. This type of social, you know it's like it's we can call it a social disease, because if people do not change their mind about this disease, the patients who are suffering will keep on suffering, and they will also succumb to many complications of epilepsy. So we need to address this issue as a social issue as well. While patients do intend to look for surgical options for refractory epilepsy, the few important factors that may be playing a role in the lack of these surgical facilities, because this domain of surgery has never been paid attention at all. As I have already mentioned, the seniors who have a responsibility are already too busy in their careers that they do not have any time to go further for further specialty training. And if we do not have some, trained personnel, we cannot hope that other generation, the new generation, will have any training in this surgical domain. And actually, this domain will never be established in our countries if we do not have any awareness, or if we do not, create a scope in this field. There's a lack of trained personnel to perform this facility, a lack of well-equipped unit, as well as the lack of specialty training in this field in most of the LMICs. There's a need to raise awareness for epilepsy surgery to get the attention of authorities to devise plan for establishing dedicated centers and training staff. There's another point that we want to share here is the preventive steps for epilepsy in the low middle income countries. Like I have said before, epilepsy in low middle income countries has all it's like there are several factors, but there are a few factors that have been recognized well, and that includes perinatal injury. So there's a need for proper perinatal care, and there is, an increased incidence, and including some people call it an epidemic of road traffic accidents in the low middle income countries. It is because of increased trafficking, while the road and the traffic control is not that well developed in most of the low middle income countries, and many people do reside in the rural areas. So where other domestic issues are there, because there are free animals who are crossing the not very good roads, who are already not very well paved, and there are stray wild animals that are crossing it, and they lead to a lot of RTAs. Some people get hit by those animals either, or they can also hit the other vehicle while they are trying to protect that animal who is crossing and walking straightly and widely in the roads. So there is a need to enforce strict law to prevent hand injuries, and there should be a proper facility to treat CNS infections in time. In our countries, CNS infections are very common, and this is also a very important cause, and even especially in the pediatric age group. A study from Tanzania suggested association of adverse perinatal event with epilepsy with an odds ratio of 14.9, and suggested that epilepsy can be prevented with better antenatal and perinatal care. So thank you for your patient listening. Again, I want to thank you for inviting me to share my work. And this is a quote for women neurosurgeons: when women can make a difference, but together we can rock the world. Thank you so much. As you know, that purple butterfly and purple ribbon is a recognized sign for epilepsy. Thank you.
Okay, thank you very much, Dr. Nur. And good quotes at the end, ya. We call it mak-mak. Jadi we call it mak-mak. So the power of mak-mak. So we have also the power of mak-mak in neurosurgery. One of it is Dr. Nur. Thanks for the presentation. And then we will ask all the presenter, please come to join in the chat room. And any attending can ask to the presenter. While waiting for the question, I will ask Dr. Fahmi to please answer the question live, because there is two questions for Dr. Fahmi. One is about peripheral nerve denervated successful of totally interoperative. How can we know that it's already totally denervated? And the second, what is the difference between TAIRA and the TAIRA procedure and the other procedure? Okay. Yes,
Okay,
Dr.
thank you
Fahmi?
very much.
Yeah.
Thank you. Thank you for the question. It's a nice question, I think. That's especially how we know that we make sure that the nerve already denervated. The first important thing is anatomical finding. In anatomical finding, we must know where is the posterior rami and medial rami and lateral rami of the posterior branch from C3 until C6. This is the challenging one, because if we look at the intradurally in C1 and C2, it's easier. But how we know in the C3 until C6, it is very challenging. From the beginning in the surgery, you must not use the monopolar. Monopolar. Avoid monopolar to dissect the between the muscle surfaces and splenius surfaces and splenius capitis. Avoid using the monopolar. You can use the mesenbum to get the plane. If you get the plane, you can easily find the C3 until C6. But if you didn't get the plane, it is very difficult. You must get the plane. And the other technique, you can use the stimulation. If you have the intraoperative nerve monitoring, you can use it too. But if you didn't have that equipment, you can use by anatomical and using bipolar or bipolar during coagulation. You can look the muscle contracted. And the second question about the difference between TAIRA procedure and Bertrand procedure. It is about the numbness after the surgery. In the TAIRA procedure, he didn't cut the sensory part of the nerve. He just cut the ventral part of the nerve. It means it is just weaken the motoric part. Yeah, no numbness. But in the Bertrand procedure, the patient usually get numbness in the occipital parts like that. Okay, maybe like that, Dr. Harry. Thank you.
Okay, thank you, Dr. Fahmi. But the TAIRA procedure actually more challenging than the Bertrand procedure, yeah, Dr. Fahmi. Okay.
Yeah, during C1 maybe.
Yeah,
during
yeah,
C1.
during
like
intradural posture.
Thank
Okay,
you.
is there any question from the audience? Dr. Inggas already here in the meeting room?
Yes, sir.
Yes, Dr. Arif
Yeah. Dr. Inggas from Jakarta. He has done many procedure for functional. Any question for Dr. Inggas? Or I will ask to Dr. Inggas.
I have question
Okay,
for Dr. Inggas.
Okay. Dr. Plasmi.
Okay, thank you, Dr. Harry. Dr. Inggas, great presentation. Congratulations. And I asked about for the DBS implantation, do you implant at all the STN or in the like GPI? How many in the GPI? What the consideration maybe? Thank you.
Thank you, Dr. Fahmi. So according to my experience that we already have in total 41 cases, but just only one I did in the GPI. Almost always in STN DBS, Dr. Fahmi. One case is because it's very severe dyskinesia after during medication. There are no but sign of the like the rigidity or tremor is not very prominent. Dyskinesia is very prominent, so that why I use the GPI for this typical one cases. The other STN because we facing about the economic burden, because the STN usually we use just only a little bit battery or stimulation rather than GPI is very big one. So that's why we use STN for that kind of our cases. Thank you, Dr. Pame.
Okay, thank you very much.
Thank you, Dr. Ingas. Actually, I have some question also for the first title, Dr. Ingas. That's really giving enlightenment to young neurosurgeons that functional is not always correlated with high tech technology, as we know DBS and all MRIs, 3TSR and all, but we also can do some interventional pain management with needle and alcohol 95%. And actually all of us, especially young nurses, must be able to do that. What is your statement about that, Dr. Ingas?
Dr. Harry is very quite is very right, because we facing in neurosurgery so many cases of pain. Even in cancer pain, we know that the pain is another disease of the patient in cancer. So that's why the pain should be resolved carefully and clearly. So that's why the quality of life of this cancer patient is improving very well. So that's why as a neurosurgeon, young or senior or even consultant, we have to know the procedure for this kind of technique. For example, in the lumbar, cervical, or degenerative cases, that is, I think that as usual technique that should be, we as neurosurgeons should be more do something beyond of that technique. Especially in the superior hypoglossal plexus block, it's very wide indication for this technique and very good result for cancer pain in lower abdominal pain. So that why some neurosurgery should be can do this technique.
Yeah, that's great. I hope that your paper will be published, and we in our center we already have submitted also impart ganglion block, and the result was very good. And this is a simple, actually not simple, but everybody should must be know to how to do it, especially neurosurgeon, because where there is a nerve, there will be a neurosurgeon's roles in that. I think that's for
that's right.
Just quote. And then for the second question regarding the DBS, the brain stimulation, Dr. Ingas, how you deal with the insurance, because the main problem in our country is insurance. Yeah.
So in the last cases, several cases of our case is covered by the insurance at all. I don't know, maybe because of apa namanya, maybe he have like a private all coverage insurance. I don't know.
Combined insurance.
Yeah, maybe they pay very expensive for that kind of insurance. So that way, everything of you have your every disease that you have, you can cover it by that insurance. I think it's depend on the insurance, I think.
Yeah. But that's why we hope that the government will change the regulatory, for DBS.
I hope Dr. Fahmi and Dr. Agus Turhan as a committee in the functional neurosurgery in Indonesia can push the collegium and Profepsi to push the government to cover it this DBS. I hope so.
Okay. As we know that actually right now in Indonesia there is only one main distributor of deep brain stimulation, and we hope that the second distributor, second type or mark of of DBS will come to Indonesia, that will change the cost maybe. Okay, so we can use DBS widely in Indonesia. Okay, thank you, Dr. Fahmi and Dr. Ingas. Is there any other question from the audience? Because we still have much time. And committee, please, can you, I ask Dr. Nur to come to our room. Dr. Nur, who are you? It's very, hello, Dr. Nur, how are you? What time now in Pakistan?
It is 12:44 right now.
Oh, yeah, yeah.
Midday.
Yeah. So it's very inspiring presentation despite of high frequency of the epilepsy. We all know that the facility is 180-degree difference with the prevalence or incidence of epilepsy. That's quite pity actually, yeah.
Exactly.
Yeah. So in Pakistan, how many epilepsy center and how often the epilepsy surgery at your center actually?
Well, it's very hard for you to believe that we do not have any dedicated center except in our Khan University in Karachi. I'm located in Lahore. I work for Punjab Institute of Neurosciences, which is considered the largest public sector neurosurgical institute, but you will be amazed that we do not perform routine epilepsy surgery. In our experience, we have witnessed only single vagal nerve stimulation being performed by our professor who has just returned from the US, and there is no other facility, and this is very, it is totally unbelievable because epilepsy is very common in Pakistan. The first city that was established in Pakistan back in 1989 was a level 2 type of epilepsy center with only neurological consultation available. Still, there is no concept of epilepsy surgery here, and those people who want to get operated, they can go to Al Khan University, and it is very, very expensive, and many people cannot even afford. So the only thing that we want and I want to do with my presentation is that I want to highlight this very important topic so that someone just take notice in our country that just things can proceed that way. Maybe it is just a lack of awareness, you may say, or there is a lack of highlighting of this issue by the doctor, by the neurosurgeon. That I said that those who get get to senior level, they are much busy in their routine surgeries that hardly go into any subspecialty training. In Pakistan, you will be also surprised to know that we do not have any specialty training and fellowship. That if we want to, then we have to go abroad. And
Dr.
only
Nos,
any
could
yes.
you please closely to your microphone?
Okay, yeah, thank you.
Yeah.
Can you? Okay, thank
Yeah,
you.
now better.
Thank you so much. Thank you so much. Yeah. I was just telling you that there is a lack of facility of epilepsy surgery in Pakistan. Only the first center that was established in Karachi was at Jinnah Postgraduate Medical Institute, JPMC. That was a level 2 epilepsy center with only neurological facilities. The first center that was established that had surgical facility was at private sector Aga Khan University. You must have heard of it. It's also in Karachi. But they do not, that's not even a frequent surgery even there. And, there's also affordability issues in Pakistan. People cannot even afford a medicine. You can just imagine that. So surgery is something that is totally, something that they cannot only fantasize about. It is very, it's a serious topic. So still in our public sector hospitals, the surgery is really rare, and many of us have not witnessed surgery in our units. In Pakistan, we have not only a vagal nerve stimulation was performed back in Pains where I do work, and just still considered one of the biggest centers in Pakistan, biggest center in our province of Punjab. Still, we do not have that much. Maybe there is basically a need to highlight this issue. So one day, the government and the hospital may take action and just establish and just try to look into it, shed some light to establish this center. So this is something that we really need to talk about, but I think that we need to highlight this very important issue. This is the scenario.
Okay. Yeah. That's very great. Yeah, we have also Professor here, Professor Zainal Mutakin. He is my mentor, my professor also, who asked me to learn more on epilepsy. So please, Prof. Zainal, come to room. Your advice, Prof.
So as we had our experience, about 800 cases for the past 20 years, that about half of the candidates for epilepsy surgery they are simple temporal lobe epilepsy cases. Yeah, simple means understanding the seizure semiology of the temporal lobe, and on MRI you will find lesion in unilateral lesion in one of the temporal lobes. So it means that you don't need any difficult, sophisticated investigations. Just understanding the semiology, good MRI with specific protocol, of course, for temporal lobe, and routine EEG. Yeah, that is the main uh, patients to start with. And then we should ask, work together with the neurologists in our hospital to set up an epilepsy monitoring unit. It means, if possible, they should have long-term video EEG in the hospital, and every patient which we consider it as refractory, those who had more than two kind of medications and still having seizures, yeah, or those anyone who that we suspected as having focal, yeah, focal or partial seizures, just put it in the epilepsy monitoring unit for EEG long term recording.
Exactly.
Yeah, that just is simple. If we find the focus on EEG long term and then do again another good, yeah, MRI with specific slices, it is either frontal or temporal with specific sequence, you will find something there. And those are our main source of patients. Just work
Exactly.
together, yeah. That's, I think, in Indonesia, not just in Pakistan or in Bangladesh or India, even in Indonesia, we still, yeah, need so many other centers for neurosurgeon to participate to develop this epilepsy surgery. Just start with simple temporal lobe epilepsy cases. With, we know that the result will be good and the surgical morbidity is very low.
Exactly. So
Yeah.
this is a wonderful
Yeah.
point that should be raised. Actually, I think there is the lack. What we have is more of awareness. Like you said, sir, this is very simple. This could be very easily employed, but I guess that there is a need to raise this away the level of awareness. Like if we go into our hospital and we say that we can just do it, obviously we can actually do it, but there will be a lot of what I will say naysayers. They will say no, it's not not our domain of specialty unless we do have an experience. If we do have any specialist there or any mentor there, then only then we can perform. So it is something that we really need to talk about. So this is a wonderful point you have raised. This is amazing. This should be done. This should be
Yeah,
said. Yeah,
Yeah.
exactly.
yeah, of course. Starting this, yeah, at the beginning, we should be accompanied or supervised by someone who is already becoming epilepsy surgeon. Yeah, to start this, maybe at least for several cases. For temporal lobe epilepsy, the technical is not something difficult, but the concept,
Yeah.
understanding why someone needs surgery and what kind of surgery that is needed for an individual, in the individual basis. Yeah, the cases are different, each cases. What we do in my center, I ask every patient who need consultation to come to my center with having a video recording of when they are having the seizures. The
Smartphone
patient
video
or the
recording, Prof.
family,
Yeah.
yeah,
Exactly.
smartphone, using smartphone to record what
Mhm.
kind of seizures, what it looks like when the seizures come. And then
Exactly.
from that we will understand it is a frontal lobe or temporal lobe. At least we know that by
Exactly, sir.
Yeah.
watching the video. And then, yeah, at least we should have one patient to start, if possible it is temporal lobe. And if the patient, we did the surgery, we should work together with the patient after surgery to make a testimony, to tell every other patient their experience before and after the surgery. That
Community
will
awareness,
invite
Prof.
some other patients.
It's
Exactly,
community
sir.
awareness. Yeah.
Yeah.
Exactly, exactly. Basic, I do think that several of our problems can be actually solved with just by just raising awareness. You know, it's very funny at
Yeah.
times to see that they celebrate epilepsy days without telling anyone that what does it mean to have an epilepsy and how to treat epilepsy actually. So it's something like I do think that we actually lack this facility. While many surgeries have been performed in our units, but since um, um, similar, I don't know, they have a fear of operating with epilepsy or something like that, because the morbidity won't be that too much to expect, and there are
Yeah.
not much complications to expect. So when we actually perform other major surgeries, why not we can just perform epilepsy surgery? It's very easy, and we can also take license with the
Yeah.
neurology units.
Yeah.
And
Yeah.
if there is something that we are lacking, or there is any point that we have to just like, I think that it should be a multidisciplinary approach. We should just send the patient first to neurology for a complete evaluation, and then just if the evaluation fits in the criterion, then we just go and just for that surgery. And this is very exactly, sir, you are extremely right, and I totally agree with that. And I do think that there should be a tendency to follow some specialty. In Pakistan, there's a lot of politics in exam and boards. So many, they just usually stick the candidates for years in their final exam, and by the time when they go through that exam and they pass, they are just so much in a hurry that they just start their own private practices, and they are just too much busy in that they do not even consider joining a specialty training somewhere abroad, and not many people even get it. So this is something that we are lagging behind, and I do think there is a need to raise awareness for that. Sir, I recently wrote a letter to editor in the JNS. It has been accepted and will be published later in this month. Sir, there are several important things that we can do actually with our smartphones. We regularly just tell our epileptic patients to send their videos to us through WhatsApp, and we usually see them and just have an idea what they are suffering from. But sir, there are other things that can be also looked for, and this is the photographical assessment of the spinal deformities. Recently they came up with a new study where they just placed markers over that spinal deformity and just measured and compared it with those which have been measured radiologically, and they said that it is very accurate. So there are several apps that are available that can be used for that, like a scopes meter and a scoliometer that can be applied with that, and smartphone can be used for several different reasons. So why not for epilepsy? And I think there is basically a need to design a specific program for that, and you can just load up those videos and just compare it. And obviously there is
Yeah.
also a need to imply the neurology units.
Yeah. Actually, many problems in epilepsy
Ah,
regarding the apps. Actually, there are international renowned apps for epilepsy called
Exactly.
Caesar Things. You can just
Exactly.
log in and register, and these apps will detect all what happened to your daily seizure activity. Thank you for Dr. Nur and also Prof. Zainal. Prof. Zainal is past president of 12 ASEAN Epilepsy Surgery Congress. He is my mentor.
Wonderful.
You may come to his center in Semarang.
Inshallah.
Yeah.
Inshallah. I will be really pleased to, and it will be a matter of great honor for me to do so if I have the privilege to. Inshallah. I just really wish
Yeah.
to.
Yeah.
yeah. We perform about 5 to 6 surgery every month, epilepsy surgery. Yeah.
Yeah.
Really, sir.
During
It's
my
huge.
residency, actually, I always I went to Prof. Zainal Center by train
For
in
1 year, yeah.
for 1 year. For 1 year.
Really?
And then I went to AIMS. But actually, the other problem is we call it work together, Prof. Zainal, yeah,
Yeah.
work together between
So,
neurosurgeon and neurosurgery.
neurologist.
Uh,
But for the
but I think
beginning, yeah, for the beginning, never expect that the neurology will send you the patient.
yeah,
Yeah,
Yeah.
only less than 10% of our patients are sent by neurologists,
yeah,
by
yeah, yeah.
radiologists. Less than
Exactly.
10%.
except he or she is your wife or your husband. So to build a good epilepsy center, it's better you to marry a neurosurgeon if you are neurosurgery or neurologist. Then the center will run well.
Yeah.
very well.
Oh, that's
Okay.
that's interesting.
Okay,
But
thank you,
that's
Prof. Zainal. Yeah, thank you,
Yeah,
Prof.
yeah.
Zainal. Thank you,
thank you
Dr.
so
Nur,
much.
for
It's a
nice
Welcome.
discussion.
it's a huge honor. So it's a huge
Yeah.
honor. I'm really overwhelmed. And thank you so much. And many best wishes from Pakistan to Indonesia. And I really wish and I really hope and pray that this we can get rid of this pandemic really soon, inshallah,
Okay.
and we can just have
Inshallah.
another outside. And
Okay.
your
Okay.
beautiful country, you have a wonderful and beautiful country, I know, and it's really a big honor and many wishes from Pakistan to you.
Okay,
Okay,
thank you.
thank you.
Welcome. Thank you, Prof. Zainal. Thank you, Dr. Nur. And so for functional neurosurgery session 1 has already ended. So please, committee, times to you. Thank you so much.
Thank you, sir. Thank you for all speakers. Before we end the session, maybe we take some picture. Please, for all participants, open the camera. Here. Santai-santai, tenang, jangan panik. Yes, on my mark. Okay, smile. 1, 2, 3. Once again. 1, 2, 3. Okay, thank you. See you later.
Thank you so much.
Thank you, Dr. Heri. Thank you, Prof. Zainal.
Oke,
Thank you,
sama-sama.
Prof.
Mas
Muhammad.
Fahmi, makasih Mas Fahmi.
Thank you. Terima kasih, Prof. Terima
Yo.
kasih, Dr. Ingas, Dr. Heri. Thank you, Dr. Nurul.
Mantap.
Mas
Thank you.
Tohar, Pak Tohar juga ada di situ.
Dr. Tohar, ya. Terima kasih.
Lagi beliau presentasi, Mas Tohar.
Okay, for the committee, can we start now or be waiting?
Sorry for all speaker and participants. We will start again on 16 past 35. Thank you.
Pardon, please. Start from
Jam
what
16.35
time?
dong. Jam 16.35 dong.
Okay. 16:35. Okay.
Terima kasih dong.
first of all, thank you for all.
NeuroAid is a natural product developed according to international standards.
Inject saline into balloon. Inflate and deflate repeatedly and slowly. Be cautious during the process of inflation and deflation. If abnormal incident occurs, stop immediately and take remedial measures. Place the tube on the distal part of balloon. Inflate the balloon, then push both tube and balloon slowly into the tubular corridor. Inflating and deflating the balloon appropriately would be helpful.
I'm Dr. Brahma Wangsa, who represents the local committee of ACNS. Welcome to all respective participants, fellow and neurosurgeons. And now, at this moment, we are in the satellite sessions of the sessions. Functional sessions. It will be consist of 7 speakers, including the moderator. Now we are going to start these sessions, and it will be led by Dr. Ahmad Fahmi as the moderator. Please, time and is yours.
Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the committee of the ASEAN Congress of Neurological Surgeons. It is a nice opportunity for us to get many knowledge from our speakers. In this session, will be start by Dr. Tohar Arifin, neurosurgeon, but unfortunately he need go to the operating theater. We need to rearrange the schedule, and then we start from Dr. Heri first. With Dr. Heri Subianto is a neurosurgeon from Dr. Sutomo General Academic Hospital. He finished his medical school and residency at Airlangga University, and he get his fellowship after 1 year, from Semarang, fellowship about epilepsy, and then he went to All India Institute, All India Institute in India with Professor Sarat Chandra to get the clinical fellowship about epilepsy. Please, Dr. Heri, you can start your presentation.
Okay, thank you so much, Dr. Fahmi. I will share my presentation live. First of all, thank you for the committee, chairman, and all for letting us sharing our experience in doing epilepsy surgery. Is it already seen?
Almost. Yes, it's seen.
Okay. So my topic is about surgery for drug-resistant temporal lobe epilepsy. This is actually quite a lot of cases for temporal lobe epilepsy. And as young neurosurgeons, we should be able to do surgery, doing also examination, including semiology, electrophysiology, and also brain imaging. So I'm currently working on Dr. Sutomo Academic General Hospital, the highest referral, tertiary hospital referral for eastern part of Indonesia and also in National Hospital. As we know, epilepsy affects around 1.5% to 1% of the world population, and the incidence is actually higher in the low middle income countries, and 20 to 40% of all patients with epilepsy will remain refractory to medical management. As we know that epilepsy surgery itself remains under use worldwide. Also, this is also happened in our country also. While in the USA, less than 1% of patients with drug-resistant epilepsy are referred to epilepsy center. And the average delay is around more than 20 years from onset of disease to the surgery. What about Indonesian population? As mentioned also by Professor Zainal Mutakin, Indonesia population estimation around 273 million. So the epilepsy population around 2.73 million, and 1/3 of it will be drug-resistant epilepsy. So the surgical candidate for epilepsy is around 400,000. It's quite huge number, and that's why we need another center doing this epilepsy surgery. And then this is a good review in the epilepsy current 2013, why is there still doubt to cut it out? As we know, there are many misconceptions. Like all drugs need to be tried, the fact is seizure freedom is unlikely after 2 drugs have failed, and then bilateral EEG spike are contraindication to surgery. The fact is patient with unilateral onset often have bilateral spike. And then another misconception like normal MRI is a contraindication to surgery. The fact is other technique often detect a single epileptogenic zone in patient with normal MRI. Another misconception, multiple or diffuse lesion on MRI are contraindication to surgery. The fact is the epileptogenic zone may involve only a part of the lesion. And then another misconception, surgery is not possible if primary cortex is involved. The fact is essential function can be localized and protected. Misconception, surgery will make memory worse if there is assistant memory deficit. The fact poor memory usually will not get worse and could get better. And then the other chronic psychosis is a contraindication to surgery. And the fact is patient will still benefit if seizures are eliminated. IQ less than 70 is a contraindication to surgery. The fact is outcome depends on the type of epilepsy and the type of surgery. And the last, patient with focal epilepsy and focal lesion can have the lesion removed without detailed pre-surgical evaluation. The fact is focal lesion can be incidental finding unrelated to the epilepsy. That's why epileptogenicity of a lesion always needs to be confirmed. And as we know, problem related to epilepsy could be anti-epileptic drug itself, could be seizure-related factor such as SADEP, etiology of the brain lesion, interictal discharge also. These all have affected the intellectual ability and also behavior. That's why, as we know in temporal lobe is very close to limbic system. This is a paper from left temporal lobe epilepsy patient. As we can see here, there is a reduced gray matter thickness and also white matter integrity in the left compared to the right. This is the left and this is the right. And p-value also show as a map of p-value. So that's why what will happen if patient have a longer duration of epilepsy, especially temporal lobe epilepsy, as we know that this abnormal weight matter tract connection will give cognitive deficit in temporal lobe epilepsy, such as arcuate fasciculus, inferior longitudinal fasciculus, inferior fronto-occipital fasciculus, uncinate fasciculus, parahippocampal, fornic, corpus callosum. These all have connection, and the cognitive deficit will display in the right side. It's like confrontational naming, delayed memory, immediate memory, and also psychomotor speed and executive function for corpus callosum. This was published online on Nature Neurology. That's why early surgical therapy for drug-resistant temporal epilepsy has a good place. This is a paper by Professor Jerome Engel, published in JAMA 2012. This is randomized control trial comparing best medical therapy group versus surgery group, and 2 years follow-up, and the result was 0% seizure free in the medical group and 73.3% in the surgery group. What about another paper? It's also showing many paper and overall surgical free, seizure free is around 70%. So in appropriately selected patient, Engel class 1 outcome will be around 70 to 80% patient at 2 years after surgery, but some will decline about 50 to 60% at 5 years. There are many factors. It's like presence of epileptic activity on EEG at 6 months post-op. That's why it is mandatory for us to do routine post-op EEG 6 months and 1 year. and then frequent preoperative seizure, general motor seizure, bilateral MRI abnormality, and increased epilepsy duration. The longer duration, the outcome is not better if we compare to the short duration of epilepsy. So what about surgical complication? Because many patients also, family of the patient, usually they are afraid with the surgical complication. So this is a paper, Evolution of Cranial Epilepsy Surgery Complication Rate, 32 years systematic review and meta-analysis published in Journal of Neurosurgery. They divide into two periods, 1980 to 1975, and then 1976 to 2012. They compare into three groups: temporal lobectomy with or without amygdalohypocampectomy, extratemporal lobar or multilobar resection, and also invasive electrode placement. And 61 article with 5,623 patients met the study eligibility criteria. And then this is the result: transient deficit, permanent deficit, wound infection, hematomas, and CSF related. And as we know here, compared to years before 95 and years after, the complication is much more less for temporal, especially. Transient deficit before 95 is 41.80%, after is only 5.2%. So this is a good paper showing minimal, or as we can see, less complication in epilepsy surgery. But as a surgeons, we have to consider not only seizure freedom, but we have to consider quality of life. So that's why in another paper published in Epilepsia 2014 by Kristen M. Fish, epilepsy surgery and meaningful improvement in quality of life result from a randomized control trial. This is also showing a significantly more patient in the surgical group achieve meaningful improvement in epilepsy specific measure of quality of life at 6 and 12 months compared to those in the medical group. And then what about the cost effectiveness of temporal lobe epilepsy surgery? It was published in Journal Epilepsy 95 by Professor Samuel Wiebe. At the first, before 8.5 years, epilepsy surgery cost may be higher than medical, but after 8.5 years, the cost will be equalized and surgery remain cheaper thereafter 8 years compared to best medical treatment. So we have to manage the goal and expectation for surgery. That's why we usually say that epilepsy surgery will try to increase quality of life. We try to diminish disabling seizure, and we try to give less anti-seizure drugs complication. What about the spectrum of temporal lobe seizure? As we know, there are actually 5 subtypes of temporal lobe seizure. Mesial subtypes usually have high frequency of aura. It's like epigastric, fear, experiential, and then frequent automatism, oroalimentary, gestural, long duration of seizure. This is the mesial subtype. And then another is temporopolar subtype. Temporopolar with short delay to first sign, and then short delay to loss of contract. And then temporal plus subtype, which have auditory, gustatory, vestibular aura, piloerection, ipsilateral motor tonic contraversion, post-ictal dysphoria. And then the lateral subtype, which has auditory, visual, vestibular aura, rare automatism, short duration of seizure, and frequent secondary tonic-clonic generalization. And then the last is mesiolateral subtype, which has initial loss of contact, early oral and verbal automatism. This all is a semiology that for us as a neurosurgeon, we should notice this all in our patient. And then how to evaluate temporal lobe epilepsy? We must find the concordance between the semiology, electrophysiology, and the brain imaging. Semiology, right now we almost all patients have smartphone, so we can ask parents to capture the video during the seizure and then showing to us during OPD meeting. Electrophysiology, we have extended EEG, ictal EEG, and brain imaging, we can do routine MRI, brain MRI protocol. And in another case, maybe we need to do PET scan. And the other is neuropsychology test, especially for live temporal lobe epilepsy. Semiology will help in determining the lateralization. It could be right hemisphere, left hemisphere. Localization could be temporal or extratemporal, and then sublobar localization like mesial temporal or lateral temporal. And then from the semiology analysis, usually we must analyze the aura around 30%, and then the epigastric aura around 30% of temporal lobe epilepsy will have aura, and the epigastric aura consists of 30% of temporal lobe epilepsy. And then we have to analyze also motor manifestation, sensory, and autonomic. Lateralizing or localizing sign in the temporal lobe epilepsy, motor manifestation. Motor manifestation could be head deviation, eye deviation, or both. Unilateral tonic or dystonic posturing, contralateral ictal paresis. And then language sign could be ictal aphasia, ictal speech arrest, verbalization or of coherent speech. And then post-ictal finding, we could find post-ictal aphasia, deficit motor post-ictal, and other signs like ictal vomiting, unilateral eye blanking, ictal automatism with preserved consciousness. It is from non-dominant hemisphere, nose wiping at the end of mesial temporal seizure, usually ipsilateral. Ictal sign for lateralization could be ipsilateral hemisphere and could be contralateral hemisphere. Ipsilateral hemisphere is like early eye and head deviation, usually start at the first beginning of the seizure. Unilateral limb automatism, unilateral eye blinking, post-ictal nose wiping, like this. Yeah. And then contralateral hemisphere could be unilateral dystonic limb, unilateral clonic limb, late head and eye deviation, asymmetric tonic limb posturing, or we call it figure of four. We can see this all clearly with only smartphone from the patient or patient family. And then what about temporal lobe epilepsy versus extratemporal? Temporal lobe complex partial seizure could be slow evolution, motionless stare, oral automatism, ipsilateral limb automatism, contralateral dystonic limb posturing, more than 1 minute usually, and infrequently secondary generalization, and then sometimes ictal speech. The extratemporal could be rapid evolution, hypermotor, motor prominent, frantic or panic behavior, secondary generalization frequent, and usually less than 1 minute. What about sublobar localization? We can divide into mesial temporal lobe and neocortical temporal lobe. The mesial temporal lobe could be 4A's: aura, arrest, automatism, amnesia, epigastric aura, motionless stare, early oroalimentary automatism, contralateral dystonic posturing with ipsilateral limb automatism, and the absence of secondary generalization. While neocortical could be auditory, cephalic, undetectable sometimes, and then early complex automatism, vocalization, gross truncal movement, secondary generalization usually frequent. As we know, this is smart home
2
video.
minutes left, Dr. Eri.
Okay.
Thank you.
Yeah, this is, as we can see, oral automatism, contralateral dystonic posturing, and it's quite long, more than 1 minute. Yeah, this is typical for temporal lobe epilepsy. We can capture this from smart home. And what happened to this patient? This patient has hippocampal sclerosis. This is another sequence. We can do the brain perfusion study also. This is video EG monitoring, but sometimes we don't have this facility. We can, if we have this facility, is quite good because there will be a synchronized while with from the video with the brain electrophysiology. I will skip this. And then what about MRI? MRI usually we have we can do with 1.5 Tesla MRI epilepsy protocol, or if we have 3 Tesla, that will be better. With this, we can do perfusion study as this patient have right mesial hippocampal sclerosis. We can see also the perfusion study also showing decrease in the right temporal pool. If it is difficult to compare or to see the hippocampal sclerosis or to see the anatomy from the brain MRI, we can use a PET scan. This one, we can see the hypometabolism on the right temporal from the PET scan. So when to operate, usually we have to follow the ELA, which is drug resistant may be defined as failure of adequate trial of two tolerated and appropriately chosen and use anti-epileptic drug schedule, whether as monotherapy or in combination, to achieve sustained seizure freedom, usually around 12 months. And then this is the standard temporal lobe, as we know, but in our center, we have many pteronal approach. With this, we can use only around 8 centimeter skin incision, around 3 or 2 centimeter craniotomy of the brain, and then surgical procedure. This is the surgical procedure. Once we open the bone, we open the dura mater, and we have to see the sylvian vein. So we do corticotomy to the temporal base perpendicular to the sylvian vein. We have to see the arachnoid layer at the temporal base. Actually, the surgical procedure is almost the same with the standard, but this is with small approach, mini pteronal approach. And then we continue to follow wing corticotomy along superior temporal gyrus, turn to M dissection to temporal base at the temporal stem to finish temporal tip lobectomy, and then ensure the corticotomy reach the arachnoid layer at the base. Then we follow the superior temporal gyrus posteriorly to find the temporal horn. Once we find the temporal horn, this is the temporal horn, we can see the head of hippocampus and also the amygdala. Then we follow hippocampus posteriorly to find the inferior choroidal point. And then we continue doing lateral and anterior disconnection of hippocampus. Then we are doing medial disconnection of hippocampus starting for inferior choroidal point. We can dissect with blunt dissector. It is important not to use coagulation in this part. And then we do posterior disconnection of the tail of the hippocampus. Important thing is to coagulate only on hippocampal artery. Then we remove the hippocampus as a whole part in order to get a good histopathologic specimen. And we continue remove the rest of anterior amygdala, uncus, and superior temporal gyrus. And then it's finished. Evaluation. And this is for the procedure. And this is another example patient with mini pteronal approach. It's also showing histopathology, focal cortical dysplasia, ILE type 1B. So the histopathology also have a prognostic factor in determining the anti-epileptic drug. Post surgery 1 month. The result operation time less than standard procedure due to less craniotomy, learning curve expected, bleeding volume, no need for blood transfusion because usually less bleeding volume, risk infection minimal, post-surgical pain minimal, wound healing better and faster, scar formation minimal, and length of stay in hospital also around 3 to 5 days. This is some of case. This is female 38 years old, age 8 onset, 9 months, worsening at 16 years old, normal developmental, seizure frequency 6 times per month with 1 to 2 minutes provocated by emotional fatigue, aura, abdominal discomfort, nausea, maximal asymptomatic period 5 days, medication already used phenytoin, Depakot, and then change to bamkitol and clobazam. Neuropsychology evaluation showing impairment of left temporal lobe. This is the MRI showing left hippocampal sclerotic with blurring also in the temporal neocortical area. Ictal video EEG showing left temporal discharge. So we did surgery, temporal lobectomy, and the focal cortical dysplasia type 1B, angle class 1, right now is almost 6 years. Sorry, it's almost 4 years. And post-op also showing minimal scar. Second case, female, 24 years old, normal developmental, age of onset 1 year, seizure frequency 1 per 3 weeks. It is clustering, disabling, provocated by emotional and stress, aura abdominal discomfort, nausea and vomiting, medication phenobarbital, Depakot, Keppra, clobazam, neuropsychology evaluation showing impairment of left temporal lobe, MRI showing also left hippocampal sclerosis with temporal neocortical blurring. Ictal video EEG showing left temporal discharge. Histopathology showing focal cortical dysplasia 1B with hippocampal sclerosis. This is also angle class 1, 4 years follow-up also. Case 3 also male, 24 years old, normal developmental, recent education is bachelor degree, age of onset 8 year, seizure frequency 3 times per week, disabling, provocated by emotional fatigue and cold weather. Medication Depakot, bamkitol, and clobazam. Neuropsychology evaluation showing impairment of right temporal lobe. Ictal video EEG showing right temporal discharge. But from the MRI, we can see it's like a kiss in the tail of the hippocampus. We try to remove the calcified part, but the vital sign was not controlled during the surgery, so we left the calcified part. But patient also have angle class 1, 4 years follow-up.
Sorry, the time, Dr. Harry, already over.
Yeah, this is the same case with I saw before. And this is the last case, female 47 years old, normal developmental, age onset 27 years, aura abdominal discomfort every day since last year. 1 year before, semiology impaired awareness, oral automatism, focal to bilateral seizure, seizure frequency once per month, but developed to disabling or clustering seizure. Medication, many medication, extended video EEG showing right temporal discharge, PET scan, right temporal hypometabolism. So we did, because the MRI quite difficult to notice which part happened with the seizure. So we did the PET scan, and PET scan showing right temporal hypometabolism. The histopathology showing focal cortical dysplasia elite type 2A with hippocampal sclerosis. This patient also angle class 1, 3 years. So the conclusion, epilepsy surgery is safe and not the last resources. Comprehensive evaluation is important. Patient and family goals, expectations are important. Also, we have to talk with them, and we need to increase awareness in the community, medical practitioner, government, and social institution about epilepsy and surgery. Thank you very much.
Okay, thank you very much, Dr. Harry. It is very great and very interesting presentation. Yeah, already many questions in the chat. After the last session, we can make a discussion if we have time for that. You can check the chat. Already many questions. Yeah, great presentation. Thank you very much, Dr. Harry. And then the second presenter will be Dr. Kevin Gunawan, a neurosurgeon from Cipto Mangunkusumo Hospital. He will present about the clinical analysis and technical approach of microvascular decompression for hemifacial spasm. Okay, please, the committee, you can share the CV and presentation, please.
Thank you. I will share. Thank you for the opportunity. I will share the screen now. Thank you.
Okay, please, Dr. Kevin, time is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Still no sound, I think.
It is unilateral initiated from the
Is my
periorbital
presentation
and can
appear?
progress to the other muscles of facial expressions. It is benign but effective.
Is my presentation appear in the screen? Dr. Fahmi?
Not yet, not yet.
Maybe the committee can help.
Please, committee, share the video again. Yeah, okay, please play. Thank you. This is Dr.
Good afternoon. Thank you for the opportunity to present a clinical analysis and technical approach of microvascular decompressions for hemifacial spasms. Hemifacial spasms is a movement disorder of facial nerve which characterized by brief or persistent intermittent twitchings of the facial nerve muscles. It is unilateral, initiated from the periorbital, and can progress to the other muscles of facial expressions. It is benign but affecting embarrassments and social withdrawals. The common cause of the hemifacial spasms is the ectatic or aberrant vessels that compress the root exit zones, and it causes the focal demyelinizations in the root exit zone, which is lack of epineuriums, which is highly susceptible to injury. This leads to two theories, which is the first one is the peripheral theories, which the compression side cause the forwards excitations to the peripheral nerve and cause the hemifacial spasms. And the other one is the nuclear origin hypothesis. This make the backward irritations from the compression side and move forward to the peripheral nerve that cause the hemifacial spasms. The other hypothetical cause is sympathetic hypothesis. The primary etiology of this hemifacial spasm is the ectatic or aberrant vessel compressions. In our cases, the most common causes is anterior inferior cerebral artery, which comprise of 74% of our case, followed by basilar artery and pica, posterior inferior cerebral artery, and vertebral artery compressions. The secondary cause include cerebropontine angle tumor, arteriovenous malformation, brain lesions, or infections. This is the size of the compressions or vessels, which is the compressions of the ICA to the facial nerve here at the root and exit zone of the facial nerve. The other clinical feature of this hemifacial spasm is the other Babinski sign, which make the specificity of the 100% and sensitivity 89% to make the diagnosis of the hemifacial spasms. It persists during the sleep and increase during stress and reduce when the patient relax. We can see here the facial nerve paralysis and Babinski sign 2. So the patients with spasms and the upward of the eyebrow of these patients. This is the grading and the severity of the hemifacial from the mild case on the localized spasm around the periocular area. This is the more severe case that the patients make the disfiguring asymmetry with continuous contractions of the orbicular muscles and affecting opening the eyes. The workup for diagnosis of these patients mainly clinicals. The MRI usually used for rule out secondary cause and for surgical planning, like the GIST and TOF sequence of these patients. We can see here, to the surgical planning, we can see how much we need to retract the cerebellum or the approach to the facial and thick nerve for these patients. The treatment consists of medical treatments like carbamazepine and Botox injections. This happens in 32 of our patients. The surgical has the highest satisfactory cure rate for these patients. The mean time to surgery in our patients is 42 months. The complete resolutions happens in 91% of patients, which recurrence happen in about 6% of these patients. The most common transient complications is the hearing deficit, which consists of 6% of our patients, and it's resolved very good. And the permanent complication consists of hearing deficit up to 9% and delayed facial palsy in one patient. Yeah, for the positioning, I use the 3/4 prone or back bench, but I prefer the 3/4 prone positions because I retract the shoulder of this patient to the anteriorly, so I can do the approach from the caudal part of this patient to the rostral part of this patient. The head fixation, I use the scalp pin fixations of the Mayfields, and secure the axilla of dependent side with pad and other pressure point like knee or hip, also padded. The neck is slightly flexed and head slightly turned from the affected side. I strap the patient to secure the patients during the table tilting during the surgery. And for incisions and durotomy, I use the curvilinear or straight incisions about 5 centimeters. I do the incisions behind the hairline for the cosmetic reasons. And then the sections of the sternocleidomastoid muscles and the splenius capitis muscle. And then we identified the asterion and the mastoid emissary vein here. And we do the craniotomy around 3 centimeters in diameters. I usually look forward to the sigmoid sinus, and during it, maybe the mastoid air cells usually opened, and I put the bone wax to close the mastoid air cells. The dural incisions can be curvilinear, triangle, or U-shape. The arachnoid dissections is very important step in these patients for the hemifacial spasms. So I exclude for the exposing. We let the cerebrospinal fluid going out and then make the cerebellum more relaxed, and then we can open the arachnoid from the bottom of the cerebromedullary fissure, and then we separate the arachnoid from the caudal end and so the rostral ends from the lower cranial nerve, and then this is the 8th and 7th nerve complex, and we dissect also the arachnoid around the targeted site, which is the facial nerve. This is the classifications from the part. This is loop type, arachnoid, perforator, branch type, sandwich type, and the tandem type. The most common opening vessel is ICA, and the compression type, the loop type of compressions. This is the loop type, this is the simple one, and this is tandem type, this is the vertebral artery, this is 8th, 7th nerve complex, and this 5th nerve, trigeminal nerve. This is the tandem type with vertebral artery and ICA, and this is the perforating type. This is the ICA passing through between the facial nerve and the 8th nerve. This is the example of the loop type in these patients. This is the compression side of the root exit zone, and I put the Teflon with the interposition technique between the facial nerve and the ICA. This is the tandem type, vertebral artery and ICA. Here, I dissect the arachnoid of the ICA and then the vertebral artery with the lower cranial nerve. The patient also had the trigeminal also in this patient, so I decompress the trigeminal nerve and the facial nerve. This is the perforating type of these patients. You can see here, this is the root exit zone with the ICA passing through the root exit zone between the 7th nerve, facial nerve, and the 8th nerve. And I just put the Teflon with interpositional technique between the ICA and the facial nerve at the root exit zone. The closure, I make sure the closure with watertight patients. Before that, we do the irrigations and make sure no bleeding, and place a piece of gel foam, a sponge down here, to make sure to protect the vein during the suturing and also prevent the blood from the outside the dura going through the inside the dura. The bone chips, sometimes I used to reconstruct the normal anatomy and layer by layer in suture, and I do not put the drain for hemifascial spasm. This is intraoperative monitoring. This is lateral spread response before the Teflon insertions, and this is after the Teflon insertions. It's already the LSR is resolved after the Teflon insertions, and it is quite good in predicting the outcome of hemifascial spasm after microvascular decompressions. If we do not sure whether there is still compression exists to the facial nerve, we can use endoscope to see through the backside of the facial nerve. We can see the nerve and the artery, and we can measure the decompressions is already adequate enough. This is the possible complications of MVD. This is transient complications and the permanent complication I have already mentioned before. This is our case. This is how to prevent the complications. Like for the recurrent side, we can identify the conflicting zone very carefully and use intraoperative monitoring like lateral spread response or the endoscope assistance. For the facial palsy, we need to do the less manipulations and gentle manipulations of the facial nerve, and the treatment usually just with observation. It is quite good resolving the facial palsy. This is one of our case at the delayed facial palsy. It happens on the day 12 post-operative day. Maybe we need to precautions for this, like intraoperative monitoring and do less manipulations for the patient, and do less manipulations also to the vessels. The etiology till now is still unknown. For the hearing impairment, we need to avoiding cerebral retractions and less manipulations in the eighth nerve. For the cerebrospinal leakage, we need to do the watertight duroplasty. Maybe we need to re-MVD or re-surgery for patients with cerebrospinal fluid leakage after it is not resolved when we put the lumbar drainage. When we need to do the repeat microvascular defibrillations, if it aborted at the first operations, we can repeat the neurovisual monitoring abnormalities, or there is clinical recurrence. This is our case. 91% of our patients usually will getting better in the 6 months after the surgery. And after the 6 months, usually the patient will not resolve the hemifascial spasm. So maybe in the 6 months, we can consider the patients to do the repeat microvascular decompressions in our cases. But most of the literature say it is quite good to wait until the 1 year after surgery. This is our case with delayed facial palsy, or this is patients. This is the MRI. We can see here there is a lot of vascular structure here before we can reach the fascials and eighth nerve complex. This is called the basilar or vertebral artery around here. Intraoperatively, we see there is vascular structure before we reach the 8th and 7th nerve complex here. And we dissect the arachnoid around the blood vessel here, and we found the root exit zone of the facial nerve, and this is the anterior inferior cerebral artery. Then we put the Teflon here with the interpositional techniques. The hemifacial spasm is resolved 1 day after surgery, but the facial palsy happened in the 12th day after surgery, and now the patient had a Haus-Bregman 3 facial palsy. This is some case from the other literature about the delayed facial palsy. Usually the delayed facial palsy range from 7 to the 23 days. There could happens delayed facial palsy for the patients after microvascular decompression for hemifacial spasm. As a conclusion, the MVD has high satisfactory cure rate for hemifacial spasms. We need to identify the offending vessels and decompress the root exit zone adequately, less and gentle manipulations of the nerve to minimize the complications. Thank you very much for your attention.
Okay, thank you very much, Dr. Kevin Gunawan. Yeah, interesting and very good presentation. Yeah, thank you. For the participant, if you have any question, you can write on the chat. If there is any time, after the session, we can discuss it later. Okay, thank you very much. And the next session, next speaker will be Dr. Adi Sulistianto from Pusat Otak Nasional Hospital, and he will present about neurosurgical treatment for cancer pain. Dr. Adi, are you here? Committee, please share the CV. Okay, Dr. Adi also have his stereotactic functional fellowship in British Columbia, University of British Columbia, Vancouver, Canada, for stereotactic and functional. Dr. Adi? Is Dr. Adi here? Okay, if not yet available for Dr. Adi, maybe we rearrange again, yeah, the speaker. We move forward to Dr. Ahmad Fawad Pirzad from Afghanistan. Dr. Ahmad, are you here? Dr. Ahmad Fawad?
So because the subjects have been presented.
Sorry, louder please. We cannot hear your sound. No sound here. Committee?
Okay. Sorry, Dok.
Yeah.
Yes. For Dr. Ahmad Fawaz, he has been cancelled because the subject has been presented 1 day before.
Okay, okay. Okay, Dr. Adi, there is not yet here. Dr. Adi? Not yet, yeah? Okay. If there, we move forward again to Dr. Bambang maybe. Dr. Bambang?
Assalamualaikum warahmatullahi wabarakatuh, Dr. Fahmi.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Bambang. He is a neurosurgeon. He is my senior. The presentation title will be Effect of Progesterone on the Expression of Delta Opioid Receptor in Chronic Neuropathic Peripheral Nerve Lesion. Very interesting. The CV, please share the CV. Okay, yeah, is Dr. Bambang in the Neurosurgery Faculty of Medicine, Mataram University, NTB Provincial Hospital, Mataram, Indonesia. He has many membership collaboration and have many continuing education and course too. Yeah. Okay, please, time is yours, Dr. Bambang. Thank you very much.
Thank you,
Please share.
Dr. Fahmi. Thank you for organizing committee. There to all participants, all my senior colleagues. Assalamualaikum warahmatullahi wabarakatuh. For this time, I will present my research, my past research. Please committed to show my PowerPoint. Okay. The title is Effect of Progesterone on the Expression of Delta Opioid Receptor in Chronic Neuropathic Peripheral Nerve Lesion. Next slide. Is the view of Lombok from height. Is the highest, the top of mountain Gunung Rinjani. I was there twice. Alhamdulillah. Slide. Okay, epidemiology of peripheral nerve injury in United States, the incidence rate is about 36.9 per 1 million person a year. In spinal cord injury incident in Europe is about 300,000 patients and about 11,000 cases a year. 2.3 cases of spinal cord injury suffered chronic pain, and 1/3 is experienced about severe chronic pain. Slide. Chronic pain is maybe from peripheral nerve injury. It's because inflammatory, nociceptive, and neuropathic. But neuropathic pain is a big problem because the prevalence is increased and no effective treatment until now. The process of neuropathic pain is influenced by many factors and different levels, including progesterone and opioid system. Why progesterone? The mechanism of progesterone to relieve pain still controversy. We need to prove the effect of progesterone to the activation of the opioid system. Slide. Is the theory before the effect of peripheral nerve lesion on progesterone. What the effect of the peripheral nerve lesion on progesterone? The peripheral nerve lesion will increase neurosteroidogenesis, genomic and biochemical. They are to increase mRNA enzyme and increase allopregnanolone. Slide. And what the effect of peripheral nerve lesion on opioid system? On opioid system, the peripheral nerve lesion will reduce the influence of mu opioid receptor and inhibit of GABAergic in the spinal cord. They decrease the number of opioid receptor, tolerance, decrease in potency of morphine, and activation of CCK. CCK is anti-opioid. And reorganization of spinal cord, anatomically, reorganization of spinal cord. Slide. It is my study. My study is to prove the effect of progesterone on the opioid system. It's a completely randomized design study. We use a rat, we start rat about 3 months, and progesterone, suspension of depoprogestin, and we evaluate the expression of opioid receptor with IHC, immunohistochemistry technique, with the antibody of opioid receptor IMG 71462. And peripheral nerve lesion here is by model of chronic constriction injury. Slide. The model of slide. The model of chronic constriction injury that I use here is a loose ligation of sciatic nerve. Like this, we operate the rat and find the sciatic and making loose ligation there. It will result in inflammation and subsequent pain, hypersensitivity after the procedure. Slide. This is the result of our study. The rat weight is about between 152 until 190 grams. Dropout is about 25 rats. Increasing weight of visitor during the treatment, during the study, progesterone group is I think it's not different. Progesterone group is increased from 172 to 213, and the control group is 169 to 215 grams. Slide. The positive expression of opiate receptor in progesterone group is 71, but in the control group only 25. The test analyze about 6.88 knot. Administration of progesterone. The result is administration of progesterone giving a positive effect on the expression of delta opiate receptor. I think this is the end of my presentation of my study slide. Conclusion, there is an increased expression of delta opiate receptors in the dorsal horn neuron of the spinal cord after administration of progesterone in neuropathic peripheral nerve lesion. Thank you, Dr. Fahmi. Thank you to all participants. This is my end of presentation. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Bambang. It's great results, yeah. For the discussion, we will go to the last time of the session. Maybe Dr. Adi already here. Dr. Adi Sulistianto.
Excuse me, Doc.
Yeah.
For Dr. Adi can attend the Congress, and now but he sent a pre-recording video.
Oh yeah. Okay. Please. I think we can play the his pre-recording video. Please. Before that, please share the CV of Dr. Adi. Okay, Dr. Adi is a neurosurgeon at the Pusat Otak Nasional, and he finished his residency at neurosurgery residency Cipto Mangunkusumo Central National Hospital Jakarta, and he went to get the stereotactic and functional neurosurgery fellowship at Vancouver General Hospital, University British Columbia, Vancouver, Canada. Okay, please, we can play his pre-recorded video. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. Good evening to all the participants of the second Asian Congress of Neurosurgical Surgeons virtual meeting. I would like to thank you to the organizing committee for inviting me to give this talk on neurosurgical minimal invasive treatment of cancer pain. I have no relevant disclosures or conflict of interest relating in giving this talk. There are several objectives that I try to achieve in giving this talk. The first is I hope the participants after this talk can recognize the importance of neurosurgery involvement in cancer pain. The second one is to review the existing neurosurgical modalities in cancer pain and evidence in backing their use. The third is to review the technical aspect of the more minimal invasive treatment of cancer pain, including percutaneous, cordotomy, and stereotactic lesioning. A brief background on cancer pain. As we all know, pain is one of the more common symptoms that neurosurgeons encounter in their patient. It is also one of the most common symptoms experienced by cancer patients. The literature cited about half of patients undergoing anti-cancer treatment experiencing pain. Even in those who are deemed to be cured, 33% experience chronic pain. And in the more advanced stages of the disease, more and more patients experience increasing prevalence of cancer pain. And about 10% of patients with cancer pain experience pain that are refractory to other kind of modalities, including pharmacotherapy and psychotherapy. If a practitioner wishes to treat this kind of pain, it is advised that he do so within the confines of a multidisciplinary team. As we all know, there are many dimensions of chronic pain, including cancer pain, not just the biological sensory aspect, but also psychological, social, and emotional aspect. So we have to treat the patient in collaboration with other disciplines, including psychologists and physiotherapists, and also other disciplines. It is also widely known in the literature that neglecting one of these aspects could lead to more severe form of pain and chronicity. And in assessing patient with cancer pain or other forms of chronic pain, we should perform a comprehensive assessment, and we should collect data so we could generate new evidence, so we could find out which treatment are more effective and start to abandon those who the effectiveness is not quite good. And treating cancer pain, we all know the World Health Organization has a step-ladder approach, starting from weak non-opioid drugs and increasing it to less potent opioids, and then increase again to more stronger opioids. But in recent years, practitioner has started to question the relevancy of this step-ladder approach and come up with a new step-ladder approach in which we incorporate various forms of interventional treatment, including neurosurgical procedures. And it is also emphasized that this kind of approach is a dynamic one, not a static one. So we could escalate and de-escalate tailored to the individual patient needs. If you're part of a multidisciplinary team which treat cancer pain, and if you are being consulted with a patient with cancer pain, you should perform a basic fundamental assessment, which includes first the type of pain. Is it nociceptive, which implies a real tissue injury which causes the pain? It could be a visceral kind of type of pain or a somatic type of pain, or a neuropathic type of pain, which implies a nerve system injury. It could be a nerve compression or an actual nerve injury into the peripheral or central nervous system, or a sympathetically mediated type of neuropathic pain. The location is important, so we could perform a more targeted neurosurgical treatment in that location. It should also be documented the previous treatment, so we could document the interactability of this pain. The cancer status is very important, in which we could gauge the life expectancy of the patient. Some forms of neuroablative treatment is more well suited for patients with short life expectancy, because this kind of treatment in patients with long life expectancy could lead to a type of deafferentation pain, which is very troublesome and hard to treat. We should also look for catastrophizing feature in the personality of the patient, in which the biological or sensory aspect of the pain is amplified. This kind of patient needs close collaboration with our psychologist colleagues. These are a short diagram composed by my former mentor, Christopher Honey from Vancouver, in which he listed the various kind of modalities in treating this kind of patients. So as we talked about earlier, we should differentiate between nociceptive pain and neuropathic pain, because the treatment is different, and the location should be delineated well, because this is our example of patient with Pain above the shoulder on the face could benefit from a trigeminal rhizotomy. And patient with a head and neck pain could benefit from a mesencephaloctomy. Below shoulder could benefit from a chorotomy. As otherwise, in neuropathic pain, patient could be more well suited for a neuromodulation procedure, or in some kind of type of patient would benefit from a certain ablative procedure. For diffuse pain, he or she could benefit from an intrathecal drug delivery system or cingulotomy. For visceral pain, it could benefit from myelotomy. For those procedures that are highlighted in red, we will talk about more in this presentation. In giving this talk, I will heavily reference this guideline just recently published by the Congress of Neurological Surgeons in the Neurosurgery Journal in March 2021 on the neuroablative procedure for patients with cancer pain. First, we will talk about chorotomy. This is the only procedure in the previously referenced guideline which has a class 2 level of evidence because the inclusion of a randomized control trial. The other procedure only cite various case series. So chorotomy in its modern iteration in the form of a percutaneous CT guided wake spinal cord ablation is started by Yücel Kanplat from Turkey. Professor Kanplat started this in 1980 using CT guided. Previously, Rosimov started this using only fluoroscopy in 1960s. So the indication is nociceptive pain, a unilateral nociceptive pain. Bilateral chorotomy has been tried before, but with increased risk. And since it is aimed at the C1, C2 level, it will ablate all sensation below that dermatome. So we advocate for pain below the C5 dermatome. And it is more well suited for patients with advanced cancer with life expectancy less than 1 year. As I mentioned before, patient with long expectancy has a theoretized increased risk of deafferentation pain. The contraindication is because we do a dural puncture, herniation could be a risk. So patient with raised intracranial pressure should be excluded. And patient with poor pulmonary function should be we should be really careful because there has been report of poor pulmonary function after this procedure, and patient with inability to lie supine for half to an hour also would be a poor candidate because we do this awake in a cooperative patient. Open chorotomy could be an alternative for these patients. So just an overview, this is a schematic diagram for the spinal cord. So chorotomy just is ablating the lateral spinal thalamic tract in the ventral lateral quadrant of the cord. Notice the proximity to the corticospinal tract. So we should heavily do intraoperative testing to make sure that we don't harm the corticospinal tract. So the equipment needed is a CT scanner, radio frequency generator, and a special electrode. I used the LC electrode from Cosman. Its diameter is about 0.5 millimeter, and it could fit well into a 20-gauge spine needle. The other equipment that we need are local anesthetic syringes, contrast agents to perform the myelography, drape, antiseptic solution, and also a safety pin or ice to test if the lateral spinal thalamic tract has been well ablated. He or she, the patient, should not feel any pinprick or temperature sensation after the procedure. So there's a diagram of the chorotomy. We aim for C1, C2 puncture. As we all know, the landmark, external landmark for C2 is about the mandible angle, and the landmark for C1 is at the mastoid tip. So we aim between those two landmarks. And first we do a puncture. In this patient, I did a cervical myelogram instead of a lumbar puncture for myelogram. And then we insert the 20-gauge spine needle, dural puncture, and then we insert the electrode. Then you can see by the impedance monitoring, on the impedance on the arachnoid space is about 200 ohms, and then when it penetrates the PL of the cord, increased to 800 ohms. And then we do stimulation, sensory stimulation, so the patient should feel a reproducible pain or warm sensation in the contralateral side, And after that we do a motor stimulation, and there should be no ipsilateral motor contraction up to 1 volt. Paraspinal muscle contraction is well expected and should not cause any complication. And then after that we ablate for about 60 degrees to up to 60 seconds, and then we test for temperature and pinprick sensation. The result is quite striking. In my experience during my fellowship, I did 8 patients, and the daily oral morphine equivalent dropped significantly, less than 50% immediately, and it's well sustained up to 1 week. And we have a paper from Dr. Aswin Viswanathan for an RCD on minimally invasive chordotomy for refractory cancer pain, in which there are 2 arms for best medical treatment and chordotomy arm. And a lot of patients from the medical arm crossover to the chordotomy arm because it is so effective. So what about the complication? There are no death side in the literature in my own experience. And there are some transient arm weakness. It is theorized due to spinal cord edema, and it should be resolved because it's only temporary. There's one patient who suffered a CSF leak. I think it's because previously we inject a lot of contrast. Now we try to aspirate CSF before we inject the contrast. So there are no leaks to the skin, but the patient exhibited some symptoms of intracranial hypotension and there are subdural fluid collection. There is one patient with a urinary retention post procedure, and this patient had a bladder cancer. So perhaps the pre-procedure functional status is not very well in this patient. Other complications cited in the literature are Hirsch syndrome, pain unmasking in the contralateral side, dysesthesia, and as mentioned, respiratory problems in patients with poor pulmonary function. So other forms of minimally invasive neurosurgical cancer treatment that we have are stereotactic deep brain lesioning. I will briefly summarize the different type of deep brain lesioning that we have for cancer patient, including mesencephalotomy, thalamotomy, and cingulotomy. I will not review the technical aspect of the procedure. For a practitioner who wishes to learn more about this kind of procedure should get in touch with their stereotactic neurosurgical colleagues. So first is mesencephalotomy. The target is at the midbrain, targeting the trigeminal thalamic tract. It is well suited for patient with unilateral head and neck nociceptive pain. So we aim at the level of the inferior colliculus, just midway between the aqueduct and the edge of the midbrain. So we lesion until the pinprick and temperature sensation is lost on the head and neck. It is widely documented in old literature, highly effective for this kind of type of pain. The other procedure is the thalamotomy. The thalamotomy procedure is well cited in the old literature, but the target is very variable. Some practitioners target the central median perivascular nucleus, other target the ventral posterolateral nucleus. It is more well suited for patient with neuropathic pain in the face and upper body. The results could pain really, but there's our old literature because in the developed countries they use more neuromodulation now. The other type of lesioning for cancer pain is a cingulotomy, in which we target bilateral cingulate gyrus. These target the more distal pathway of pain, the cognitive processing of and affective processing of pain. So the patient doesn't feel, as we say, doesn't feel bothered that much by the pain, although they still feel the sensory aspect of the pain. The target is 24 millimeters behind the tip of the frontal horn and it's about 7 to 8 millimeters from the midline. And because it targets the final pathway, the more suited for patient with diffuse pain. And because it's also part of the limbic system, some patients feel confusion and apathy after this procedure. So we should expect this and we should prepare by closely collaborating with our psychologist, psychiatrist colleague to handle these kind of symptoms. So what about neuromodulation? Some type of neuromodulation, especially intrathecal drug delivery system, is well suited for patient with advanced cancer pain. But since the cost, these are not very affordable in lower and middle income countries. But as neurosurgeon, we should still be familiar with that because we are very familiar with the neuroanatomy and neurophysiology of the nervous system, and we can handle the complication. Because a lot of our colleagues who is involved in interventional pain management also do this, but perhaps we should be closely collaborating with them because we are very familiar with the complication and the anatomy and the physiology. I think that's all for my talk. Thank you. I hope we can take better care of these cancer patients.
Okay, thank you very much. Now we move forward. I think Dr. Tahar already here. Please share the CV of Dr. Tahar from the committee. Dr. Tahar will be present about the hemispherotomy for drug-resistant epilepsy in an Indonesian population. He is in neurosurgeon in Karyadi Hospital, and he is especially in stereotactic and functional neurosurgery too, and he doing many epilepsy surgery. And he went to Japan to do his fellowship. Okay, please, Dr. Tahar, time is yours, please.
Thank you, Dr. Ahmad Fahmi, for the introduction. I would like to present my work about the hemispherotomy for intractable hemiplegic epilepsy in Indonesia. This work was published in Epilepsy and Behavior Reports last 2 years. Know that the history of hemispheric disconnection start when then they describe anatomic hemispherectomy as a treatment for glioma in 1928, and now hemispherotomy technique was as a familiar as brain craniotomy for the hemispheric lesion. Hemispherotomy is a surgical treatment indicated in intractable epilepsy with unilateral hemispheric pathology. Patients with pharmacoresistant infantile hemiplegic epilepsy are potential candidates for this procedure. Acquired etiology such as Rasmussen encephalitis, Strauss-Weber syndrome, congenital porencephaly, perinatal stroke, and another disturbed congenital neuronal migration such as hemimegalencephaly, cortical dysplasia, hemiconvulsion, hemiplegic epilepsia syndrome is an indication for the hemispherotomy. There are 3 techniques of surgical hemispherotomy that are familiar to us. First is vertical parasagittal hemispherotomy introduced by France neurosurgeon Professor Dilalong, and second is peri-insular hemispherotomy, and the third is modification of peri-insular hemispherotomy that introduced by Dr. Shimizu and Dr. Maihara. We worked from 1999 to 2020. It means more than 20 years. And we just found that only 2.7% from our cases that there are indication for hemispherotomy, only 18 cases. So this is the clinical data, 9 male and 9 female, average from 14 years old. Yeah. And the onset range from 3 months to 7 years old. Yeah, and average delay from onset to surgery is 10 years. It means that 3 to 20 years. Yeah, because the lack of our service in epilepsy surgery. So the underlying pathology, the most cases are congenital porencephaly in 10 cases, and only stroke Weber syndrome in 1, Rasmussen encephalitis in 1, and mesial temporal sclerosis with bilateral encephalomalacia in 1 cases. And there is 4 cases in hemispheric hemiatrophy. We did 70 cases with peri-insular hemispherotomy that we are familiar, Prof. Zainal and me are familiar with this technique. Yeah. The outcome results, there are improved outcome in 8 patients. Yeah. Sorry, in 11 patients, and angle class 3 in 4 patients, and in class 4 in 1 patient. This is cases of 40 years old with right side infantile hemispheresis. So porencephaly cyst in her left hemisphere. Yeah. And left-sided hemispherotomy was performed, and post-operative observation result in complete seizure freedom in 80 months. This is the graph before MRI before operation. This is the after operation. Talk about the prognosis. Acquired lesions as porencephaly were known to have the better prognosis along with Rasmussen encephalitis, Weber syndrome, compared to the neuronal migration defect like cortical malformation due to suspect involvement of the contralateral hemisphere. Poor prognosis predictors include contralateral abnormality. It means that the EEG focus is not isolated on the same as the hemispheric lesion. So there's the poor prognosis. And abnormal hemisphere were extensive insular and subcortical heterotopic gray matter in imaging studies. Compared to the anatomical and functional hemispherotomy, modified PIH has less risk of surgical complication and reoperation rate, although the seizure outcome did not significantly differ between the techniques. Transient postoperative hemiparesis or hemiplegia is also seen in the most patients underwent hemispherotomy. However, this phenomenon does not last in long term. In our series, for patient developed temporary worsening hemiparesis and 1 developed transient hemiplegia, which we promptly treated. In highlight, hemispherotomy is surgical procedure of hemispheric disconnection with good seizure-free outcomes to treat intractable infantile hemiplegic epilepsy and has lower rate of post-operative complication compared to hemispherectomy. Hemispherectomy means only disconnection. We are discussing our experience performing hemispherotomy in selected cases and presenting the result of this relative outcome procedure in our centers. To our best knowledge, this is the large report of hemispherotomy documentation for intractable epilepsy in Indonesia. And thank you. This is the final of my presentation, and I'm send back the time to Dr. Fahmi. Thank you.
Thank you very much, Dr. Bahar. Very interesting, interesting and great presentation. Yeah. Okay. Because we have a little time, we can the presenter can give the closing remarks and adding the. I looked at already answered and the chat. Yeah, the questions. If the participant have any question, you can directly raise your hand and you can discuss with the presenter. And for closing remarks and maybe adding some answer from the question. Maybe we can start from the first speaker, Dr. Harry, please. Maybe you have closing remarks or adding some explanation of the question already write in the chat from the participant.
Yeah, thank you so much, Dr. Fahmi. Actually, I have asked a question by chat. Most important thing, what mentioned by Prof. Zainal Mutakin previously, if you want to start epilepsy surgery, start with a simple epilepsy surgery, which is temporal lobe epilepsy. That's why knowing the semiology, EEG, and also MRI is important. That is what I have learned much from Prof. Zainal Mutakin. If you find some difficult case, don't bother to refer us to other senior colleagues. It's like Prof. Zainal. He will very kind, and he will fly to your place to assist you doing surgery and all. And we can also discuss together all the epilepsy type in epilepsy division. Thank you.
Okay, thank you very much, Dr. Harry. Maybe because it is a correlation with epilepsy, yeah. Maybe the second one, Dr. Tohar. Please give your closing remark. And I have one question for Dr. Tohar. How about in the eloquent area, like in the left side about hemispherotomy? Please give the answer and closing remark for that. Thank you.
Biasanya, usually the eloquent cortex will migrate or compensate to the other side of the non-lesional side. So biasanya akan diambil alih gitu.
Because of the what is called
because of plasticity. No, because of plasticity of the developing cortex. The most important thing in hemispherotomy is that we should ensure that the semiology, EEG, and MRI is concordance. Means that if the lesion in the left, it means the MRI in the left, and then EEG in the right, never do the operation. But if the MRI in the left, EEG in the left, semiology in the left, surgery will have the benefit. Okay, thank you, Dr. Fahmi.
Okay, very complex, yeah. Epilepsy, it is depend on the patient selection, yeah. Yeah, you are a great person, yeah. Both of you. Okay. Thank you very much.
May I have some comment, Dr. Fahmi?
My mentor, Prof. Zainal.
Prof. Zainal. Okay, brief. Please, Prof. Zainal.
Yeah,
please.
for hemispherotomy, actually, yeah, if the patient is still very young, yeah, the hemiplegic or hemiparesis after surgery will last only less than 1 month or 2 months.
Yeah.
It will come back because it will the proximal side. It means that upper arm, upper leg, and jadi lengan atas, lengan bawah, tungkai atas, tungkai bawah itu diambil, will be taken over by ipsilateral hemisphere. The only permanent complication is the
tapping
arm, the hand and the foot.
Hand grip and foot.
The drop foot.
Yeah, foot tapping, bro.
Foot tapping. The patient will have that permanently. So still the patient may run, but little unstable, unbalanced like that. So never worry about the complication of hemiparesis because it will come back. But we will create situation with no seizures and the brain will be preserved for the later function as the child will grow. That is most important. It is like trade-off, yeah, trade-in, trade-off. We should, the patient, the family should sell the epilepsy, but they will get the mild hemiparesis. Yeah, just that. Yeah, that is very important. And I would like to comment on the presentation by Dr. Kevin on hemifacial spasm. A few years ago, everyone did put interpositioning, put something in between the REZ, and the vessel. But recently, yeah, it has been left that way. We do not, so the way now is do not put anything on the root entry zone in or between the vessel and the root entry zone. We should transpose, yeah, move the vessel to other place and stick it the vessel, pull it the vessel to other places away from the REZ. I think that, yeah, I think we all should learn something that do not put anything on the REZ. That is very important because you see the complication of paralysis, facial paresis, facial palsy seems to occur, yeah, related to the ischemic condition caused by another compression. Yeah, chronic ischemic condition. Thank you. Just that.
Thank you very much, Professor, for the comment and the epilepsy collaboration. And now, Dr. Kevin, your turn. Yeah, to give the answer, some of the adding the answer from the participant and from Professor Zainal.
I think
Comment
I answered
and closing remarks too, please.
Well, yes, thank you, Prof. Zainal, for the comment. I think there are two techniques regarding the microvascular decompression. That is interposition technique, like what I perform with my presentations, and also there is a transpositional technique, but I haven't have experience enough to do the techniques. Maybe later I will try. But the important point is we need to search for the root exit zone clearly before we decide which compressions of offending vessels site we need to release from the facial nerve. Maybe that is the important point. Thank you.
Dr. Fahmi still mute.
Still belum di ini.
Sorry. Thank you very much, Dr. Kevin, for the closing remark. And then the last one will be Dr. Bambang. And I look that Dr. Adi already here too. Maybe after Dr. Bambang, that Dr. Adi can little bit speak about the conclusion and closing remarks for his presentation. Okay, Dr. Bambang, please. You have.
Thank you, Dr. Ahmad Fahmi. Thank you for all speakers. Thank you, Professor Zainal. Thank you to my senior, Dr. Made Ingas, for the question. This is my study, is a private study, and I will continue this study with the other project. Thank you. That's my great opportunity to present my study here. Thank you, Dr. Fahmi.
Okay, thank you very much, Dr. Bambang. And the last one will be Dr. Adi. Please give your closing remarks or the conclusion. Yeah, we already play your presentation.
Thank you very much.
Dr. Adi.
Thank you very much, Dr. Fahmi.
Presentation. Very good presentation. Please.
I was held up because of an emergency. I did not realize changing the schedule. Thank you. Sorry for just showing up, but yes. So my talk was about the lesser known neurosurgical modality in the treatment of cancer pain. I think we should become aware of this kind of treatment, cordotomy and stereotactic deep brain lesioning for cancer pain, because we can offer so much more to this cancer pain patients. and we will increase their quality of life, and we should also become more collaborate more with our palliative pain care colleagues. Thank you. If there's any other more question or suggestion, I will happily comment or answer. Thank you, Dr. Fahmi.
Okay, thank you very much, Dr. Adi. That's our last session. And then I would like to give thank you to Professor Zainal Mutakin, Dr. Heri Subianto, Dr. Tohar Arifin, and Dr. Kevin Gunawan, Dr. Adi, thank you very much, and Dr. Bambang Prianto for the good and very excellent presentation for all of you all, and Dr. Madi Inggas too in here, and all of the participants. Thank you very much. Maybe for the follow-up question, maybe many questions from the participant, you can contact the presenter, I think. Yeah, it's very interesting presentation all. Thank you very much. I give the time to the committee. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, thank you for all the speaker and the moderator for the great the presentations. We are grateful for the time and effort you took to share your thought and experience with us. I believe we can benefit immediately from the case you are presented. Your enthusiasm and the passion is contagious. Thank you again for your contributions, and see you on the closing ceremony. So, thank you.
Maghrib di situ atau kerja sih lah ya.
Okay, for all the participants, maybe we can moving to the main room for closing ceremony. Thank you.